and welcome to another Piper Pod. Today we're going to continue with pharmacology and we're going to look at respiratory pharmacology. But in order to narrow our field a little bit, because obviously we can look at all the antimicrobial agents used in respiratory disorders, we're going to focus on conditions of the respiratory system and the main conditions that we get. So we're going to look at medication used in the management of asthma and also COPD. Now, the reason these two particular ones are important is because essentially anyone can get asthma-like symptoms, and the medications used in asthma and therefore COPD as well can also be used in acute cases of respiratory distress or infection. It's also very important to know because it's a global consideration and it affects the very young all the way up to the very old. So they're conditions that you will definitely see whilst working in the clinical field, and having a better appreciation of the pharmacology will definitely help you out. So we'll just look at the two disorders that we spoke about, so asthma and COPD, and we'll just bring up a few things. Now, we're not going to go a lot into detail on the anatomy, physiology, or the pathophysiology of these conditions. So if you feel like you need a refresher, then I recommend that you stop this video, go back to anatomy, physiology, have a look at the respiratory side of the house, and then if you want, have a look at the pathophysiology of the respiratory system, and then come into the pharmacology. Doing it that way will help create a full picture of what we're talking about. But just a few things to bring up looking at asthma. We all know the usual description, if you will, of asthma. Okay, it's a reversible condition of bronchospasms, mucohypersecretions, and oedema or swelling in the respiratory tract itself. Now, the triggers are classically those allergy-based, okay, and we always throw out that the causes of asthma is, your allergies, your grasses, your pollen, but then we say that stress and cold weather and smoke, chemicals can also bring on an asthma attack. So just to delve into that a little bit further, we need to realize that we can actually break asthma up based on its causes, and its two causes have two completely different pathogenic responses. So the classic one that we all know is the extrinsic side of the house, and this is a cellular response responded by the release of cellular mediators like your IgE, your mast cells, your leukotrienes, which are basically the main inflammatory mediators that cause the profound inflammatory response. Now that, classically, as we know, causes your bronchoconstriction and your increased mucus production. But we also have things known as the intrinsic factors. Now this here is classified as an alteration of the autonomic nervous system function. Okay, so the first one we spoke about is eosinophilic, so involves eosinophils, IgEs, and the release of histamines and leukotrienes, whereas this one is purely an autonomic nervous system function, where what happens is the body actually becomes parasympathetic dominant. So in the presence of the parasympathetic dominance and the inability for the sympathetic to kick in under normal circumstances like fear, stress, or anxiety, you're going to have an increase in bronchoconstriction when the body wants bronchodilation, and you're going to have an increase in mucus production as a means of protecting the body, but in this case making it more difficult to get air out. So the end result is always the same. We get bronchoconstriction, we get the increase of mucus production, but it's important to know the difference because certain medications won't have any effect on the intrinsic pathway if we choose to use it, and will only be effective on the extrinsic pathways that we'll talk about. Now, when we look at COPD, it's just a way of defining that these people are chronically obstructed. Okay, so your classic causes is your chronic bronchitis and your emphysema, but you can also get your hypersensitivity pneumonitis, your pneumocanosis, your severe asthma, they're all linking into COPD or COAD group in these diseases. And they're also classified now as what's known as a chronic airway limitation. So they're really bringing in the gaps of what happens. If someone has chronic airway limitation to any extent, then basically they get lumped into the same sort of category as these irreversible obstructive airway diseases. Now, the main cause to it is obviously smoking and your environmental exposure is usually based on work. So things you sort of can't control because our education wasn't that great years ago. So it affects mostly the elderly. There's both asthma, which is usually associated with the children. So we end up getting, as I mentioned, a full spectral disorder. Now, the thing to understand about COPD is it is irreversible. So destruction to the alveoli or the pulmonary tree generally means that any medication that we give is not often given as a means to improve or to cure, but it still has some physiological effects that improves the quality of life. So our goals shift. So we're more interested in improving quality of life as opposed to reversing things that have already occurred. Okay, so let's look at our clinical decision process. Now, obviously we can look at it from 2 points of view. We have the acute phase where we have an outbreak or an exacerbation of a condition, which is what we are going to focus on. And then also there's the considerations associated with your long-term medication management of these conditions. So a lot of the time, people who have a respiratory condition will go away with certain medications and they'll use those medications based on a plan that has been set up. So if we're working in a hospital and we have patients with a respiratory disease, we need to focus on the respiratory distress, the signs and symptoms of the distress state that they're in at that point in time. Because each one of these disorders that we talk about can have an acute aspect to it. So we need to look at their respirations, all aspects of it. Are they coughing? Do they have stridor? Is there any restriction in their airway? Their breathing posture, signs of cyanosis, oxygen saturation. On top of that, we can use lab tests, things like our spirometry, so pulmonary function tests can be a great indication of compensation. So a patient may come in appearing fine, but underlyingly they may be compensating. This is also true with our blood gases. Okay, blood gases don't lie, it tells you exactly what's happening in the body. So we can use these tests in order to pick up early signs of compensation, because we all know that compensation only goes so far. Once we finish our assessment and with that come up with some form of plan usually associated with the patient, we need to look at implementing new plans or reinforcing that plan that's in place. So the primary goal for respiratory distress management is always having the patients and their families educated on the management and what the actual acute plan is for the overall management. Now the reason that is these people often don't live in hospitals. Okay, so they are going to go away and they are going to have the knowledge themselves, and their loved ones are going to have the knowledge themselves in order to start the treatment when things go south. Okay, so that's always the primary goal. We want to prevent them coming back to hospital and improve their overall quality of life. Never assume when you get a new patient that they've actually had full education and they understand their illness or their medication regime. Okay, a lot of people, when they get educated, they make rash assumptions, if you will, and they draw conclusions on incomplete information. So their education may have been fine, but until they educate them further, they may not see the full picture. So it's always important to keep educating them. Now, by educating them, you improve their compliance. So the use of the medication, which we'll talk about, because a lot of the medication need to be given a certain way in order to be really effective. They need to know how to use a spacer. They have to have an action plan. Okay, and the action plan has to be in language that they can understand themselves. Now, there's a really good example of that the Asthma Council has brought out that we'll look at in just a little bit. Another thing that needs to be encouraged as far as understanding goes, is not to put off taking the medication, not to encourage the habit of, oh, you'll be right, see how far you can push it before you're taking the medication. Okay, when we're dealing with respiratory-based problems, you actually want to initiate a plan at the first signs of shortness of breath. The reason for that is once you're having the first signs of respiratory distress, then something in the body has initially gone wrong, either extrinsic or intrinsic factor when we're dealing with asthma, or some form of exacerbation with COPD. The longer it goes on, the hypoxic state is going to cause anxiety, and anxiety itself is going to exacerbate the actual respiratory conditions. And then it'll get to the point that you'll actually be chasing the symptoms as opposed to just fixing it at the start. When they're taking their medication, especially inhales, make sure that they're sitting upright and educate them on the difference between an MDI versus a nebulizer and reasons they may need to come into hospital in order to get a nebulizer as opposed to just using the MDI itself. Okay, as mentioned, here is an example of an asthma plan that is brought out. As you can see, it's quite simple. It can be used for patients that have trouble with English or understanding complex language, and it's also a great tool for children because you can include the medications that they're on, either the immediate short-acting ones, the longer-acting ones, the prevention type of ones which are associated with your corticosteroids and that sort of thing. So you can include all of these things. Now, a lot of these drugs have been color-coded for this sort of ease as well. So the whole education side of the house is getting a lot better, and the actual National Asthma Council has done a wonderful job at educating and keeping track of what is actually done. So when they go back and see the doctors or they see their primary care, they can actually educate how well the treatment is going and if there needs to be a change in the asthma plan as well. Okay, once you've done your treatment or they've been under treatment, you need to monitor the effectiveness of that medication. If it's not good enough, then we need to ramp it up. People can decompensate very quickly with respiratory problems, especially children. So we need to assess how well the medication is. Auscultate the lungs, see if there's any coughing still, look for signs of mucus secretions, and look at their quality of their rests. Are they actually just breathing normally, or are they still using accessory muscles? Are they tachypnic, things like that. Monitor their O2 sats as always, but don't just use that as your telltale sign that everything is fine. With certain medications, it comes with adverse effects. We'll go through those particular ones as we move into the meds themselves, but just be aware that some effects are quite normal and the patient should be educated on them, whereas other effects are undesired and needs to be a consideration for changing the actual regime itself. Okay, let's get stuck into the actual pharmacodynamics of the medications that we can use. So we'll start with the bronchodilators. The bronchodilators are fantastic and they're put into place in the acute side of the house. So the initial management of shortness of breath or dyspnea is your bronchodilators. It's used in a lot of disorders right through the asthma spectrum into COPD and all the disorders leading up to COPD. So there's a bunch of different classes of bronchodilators. So you have your beta-2 agonists or just your beta agonists. You have your muscarinics antagonists, and then you also have your methylanthines. Now these drugs are used to trigger bronchodilation. So each of these particular classes are used to trigger bronchodilation, but they work different ways. So they respond to a different mechanism in order to cause that bronchodilation. So the first one, we'll look at our beta agonists, or most commonly known as sympathomimetic agents or beta-2 agonists themselves. You can even throw in an andretic there if you want. They have lots of different names. So these primarily, the way that we give them, are designed to stimulate the beta-2 receptors in the bronchial smooth muscles, therefore causing bronchodilation. So they actually will trigger the beta-2 receptors in the lungs, causing a bronchodilation. Now, the reason that we give them via inhalant is there's two different types of beta receptors in the body. You have your beta 1 and your beta 2. Now, both of these are found throughout the body. It's not just the lungs that they're found. Beta 1 is primarily found in your heart, and it's responsible for accelerating your heart rate. Okay, that's what we know as the beta 1s. Now, these drugs will actually stimulate both of them. So if we have a situation where we're giving these beta agonists and it actually gets absorbed mostly in the bloodstream, then you're going to have an effect associated with tachycardia. Okay, that's why your salbutamol will actually give tachycardia, because getting some in the bloodstream is unavoidable. So it does stimulate the heart, and it will actually cause tachycardia. If we give it ineffectively, like in the absence of a spacer, push it in and most of it goes into the mucosa, then what you're going to get is you're going to get more of an accelerated heart rate effect and less of the bronchodilation effect. So the beta 2 agonists work by actually activating and tapping in to the direct receptor of the beta region. So if you want it to work on the lungs, it has to get into the lungs. That's why using a spacer is very important, because you can create an atmosphere in which you breathe in, creating that negative space, and all that beta agonist will actually come in and work directly on the lungs themselves. Now, this is consistent to why there's been studies that suggested that the use of properly administered MDIs with a spacer is more effective than nebulizers themselves. Now, two different classes you can get of the beta 2 agonist is your short-acting and your long-active. So they're often color-coded. So the blue ones will be the short-acting, and the green ones, or your symptom controllers, are your long-acting. So salbutamol, classic short-acting one, and salmeterol is a classic long-acting one. Now, both of them have the side effects of tachycardia, feeling of palpitations, and then your tremors as well. The next class of bronchodilators is what's known as your muscarinic agents. So what these particular ones do is they'll come along and they'll actually block acetylcholine. Now, acetylcholine is used to encourage bronchoconstriction. So in the absence of having that acetylcholine receptor tapping into the bronchial wall, the smooth muscles, then you're not going to have bronchoconstriction, and then it's going to encourage bronchodilation instead. So because it blocks the receptor, it allows the noradrenaline receptor to kick in and therefore cause your bronchodilation. This is obviously very effective in those people suffering from the intrinsic factors associated with asthma. Now, these are slower onset than the beta 2, obviously, okay, because it's associated with the parasympathetic nervous system. And these also have a short-acting symptom reliever and a long-acting symptom controller as well. So ipratropium bromide is your classic short-acting one, and tiotroponine is a classic long-acting one. Now, side effects are associated with your anticholinergics. So you get your dry mouth, your dry mucosals, you can get pupil dilation, and long-term use can be associated with glaucoma. Now, the last class of drugs you may not have heard of, and the reason for this is they're actually the oldest class of bronchodilators. So they're not commonly used anymore because they have massive side effects. So these are your methylansthines. Now, the classic one that you'll see on the screen in front of you is your thiophyllines. Now, thiophyllene is a drug that is avoided a lot of the time because it has a high incidence of causing adverse drug reactions. Now, the way they work is quite interesting. So what they do is they enter the actual cell and they block your phosphodiesterase. Now, what happens when they block this phosphodiesterase? It actually increases the levels of your cyclic AMP. Okay, so it doesn't allow for cAMP to become AMP and therefore continue within its cellular cycle. Now, as a result of this build-up, it actually increases cellular activity in the bronchioles, and therefore stops your constriction itself. So because of the increased activity, it doesn't allow for your bronchoconstriction and actually will encourage bronchodilation. But as mentioned, it's a lot of different side effects associated with it. Now, there's no specificity of action in a systemic response, and these particular drugs are difficult to give because they have a very narrow therapeutic range, which means they have a narrow margin for safety. So it's very easy to overdose. They should be avoided in children and old people at all cost. And they also have very unpredictable effects associated with liver and cardiac outputs. So if they have any patients with comorbidities, they shouldn't actually take. The main side effects that you'll get is ventricular dysrhythmias, okay, insomnia, and they can also bring on your seizures as well. Okay, moving on to your classic preventative treatments. We'll start with the main one, which is your corticosteroid, okay, or your anti-inflammatory agents. Now these obviously are given, as far as the pharmaceutical side of the house goes, to control inflammation. Now they take a long time to kick in. Now the main natural corticosteroids produced by the body are your cortisol and your aldosterone. When we're giving corticosteroids, we have to understand that we want certain effects, but we don't want all the effects that are possible for a corticosteroid. That's why over the years the pharmaceutical side of the house has designed different ways in which to administer corticosteroids. So you have your inhalants, which is the best one to use associated with treatment in respiratory, and then you also have your systemic, which is your oral and your IV corticosteroid. So when we're dealing with inhalant corticosteroid, beclomethasone is a classic one, as well as flucloxazine dopalate or Becanase. Yeah, you'll often see. The advantage of these ones is they're inhaled directly onto the site of the inflammation that you're worried about. Okay, so corticosteroids have the ability to turn off most causes of inflammatory mediators. Okay, so they have huge effect on inflammatory cells, and then they also have additional effects associated with endothelial linings, releasing additional mediators like your cytokines in order to encourage cellular proliferation and inflammatory responses. So they're very effective, but they take a long time to kick in, and they can obviously affect the whole body. So by giving it just into the lungs, we'll actually sit on the lung tissue and it'll work on those particular endothelial cells themselves. So it's definitely preferred over your oral or your IV, except if there's an emergency or an acute exacerbation. Side effects for the inhalants, you can get coughing because of a dry mouth, and you do have an increased risk of fungal infections within the mouth. When you're given them systemically, that's not the case. You'll often get IV doses in emergency, hydrocortisone, dexamethasone, and then you should be encouraged to go on to oral as soon as you can. And prednisolone is a classic oral corticosteroid. Now, in the past, there's been a lot of talks of whether or not people should be weaned off from high doses. So what used to happen quite classically is people would get put onto a high dose, and then they'll be given high dose oral for 2 to 5 days, and then they'd stop. And then they tried to put them on for high dose orals and then wean them off over a week. But there hasn't been a lot of studies that's proven that either way is more effective than the other. So it's literally going to come down to the individual who's prescribing it these days. If they're only used in the short term, then they are very effective in reducing the severity and the duration of an attack, and also preventing adverse effects. So they're almost as safe as the inhaled corticosteroid. If the long-term use is required, so people have a lot of exacerbations that constantly get given corticosteroids, then the ability to prevent adverse effects is diminished. Now, certain adverse effects can be huge, So we're talking hyperglycemia, hyperkalemia is a classic one, fluid retention, obesity, flat storage, huge susceptibility to infection, effects on the bones, the list continues. Okay, so long-term use of corticosteroid is not associated with safety or the absence of adverse effects. Okay, the last three classes that we'll look at are quite different in their nature, which is why I brought up this particular slide, because this slide allows us to look at all the drugs that we've talked about and then also introduce the last three as well. So just starting right at the start, well, the picture that you're looking at here is you've got the red tube at the top, that is your bloodstream, okay, and then everything associated with what's found in the blood. And then you've got your red bronchi. So that's the smooth muscles of your bronchi itself. Okay, and we've got a nice little picture of a normal bronchi showing you the neurotransmitters that come in that are color coded. So just to give you an idea of what you're looking at, so when I mention the drug classes, it makes a little bit more sense. So number one is your androgenic antagonist. Okay, so your beta 2 agonist is number one. So that affects by acting on the sympathetic neurotransmitters, which is your noradrenaline or norepinephrine. Okay, so that works on there, causing direct bronchodilation. Okay, number two is your anticholinergic or your anti-muscarinic agent. Now that works by blocking acetylcholine, which only allows for noradrenaline to kick in. Number three is your methylxanthines. So that one there, as you can see, works directly in the actual cellular structure of the bronchi in order to prevent bronchoconstriction and encourage bronchodilation by increasing the CAMP, the levels within it. Number four is what we just spoke about. Okay, that is your corticosteroid. It allows inflammatory mediators to be produced, but then it just stops them right at the actual site, so therefore they can't have any effect. Okay, now moving on to our new classes, we'll start with number 5. So these are your mast cell stabilizers. Okay, and these are inhalant medications that are given prophylactically. They're mainly used in children, and the idea of them is to reduce the frequency and the severity of attack. Now they're less effective than inhaled corticosteroid, but a lot safer. Okay, so they are directly designed to prevent the release of the mediator from the mast cells themselves. Okay, so all the mediators that the mast cells release, then they are going to prevent that release. Now, it has to be noted that they are completely useless in an acute attack, because in the acute attack you've already got symptoms, therefore the mast cells have already ruptured and the mediators are already flowing through the system. So that's why this is only a preventive drug, because it stops the actual initial release of the mediators from the mast cells. An example of a mast cell stabilizer is sodium cricomyglate, or Intal. Makes it a lot easier to say. Okay, number 6 is actually a leukotriene receptor antagonist. Okay, now what they are designed to do is they also are used as a preventative treatment and used to relieve symptoms, but they're involved in actually blocking the leukotrienes from activating the receptor sites, causing the localized inflammation. So leukotrienes is a class of inflammatory mediators that are mostly released by your eosinophils and your mast cells. So because they block the actual receptor, this drug blocks the receptor that the leukotriene would usually activate, therefore causing the inflammatory response and the vasodilation, that side of the house, then obviously it's effective in that nature. Now these are found mostly in tablet and chewable form. Like as mentioned, they're a good preventative treatment and they're not used to relieve symptoms. Your Motella class or Singular is the example used there. Now number 7 is a class of drug that's not as commonly used anymore, but your omalzumabs, are a class of drugs that are used to actually block and bind to human IgE antibodies. Okay, so they're very effective in your extrinsic asthma side of the house. Okay, very, very effective just in that. The main one that's found in Australia is Xolair, so that's XOLIAR, and that's a subcut injection that's given every 2 to 3 weeks depending on the person's body weight and their baseline IgE levels. So IgE levels are only going to be elevated in people that suffer from chronic allergic-based asthma. So by having a particular drug that binds to the IgE antibody, it prevents that IgE binding to the mast cell and therefore causing that mast cell to rupture. Okay, pretty cool. So all of this works together. The overall goal is obviously to control the symptoms of asthma. It needs to be noted that unfortunately, whilst these particular drugs sound fantastic, it has a huge potential for causing anaphylaxis and also bleeding as well. So as I mentioned, no drug can be given in the absence of risks. There's no such thing as a safe drug. Okay, just to finish off, we'll have a look at considerations that can be brought into play in order to determine whether or not the conditions are controlled. So when we're looking at asthma, the way to think about asthma is we need to look for those telltale signs of poor control. So if someone has to use their medication, being their relievers, more than 3 times a week, then that's poorly controlled. The goal is to have control over the symptoms. If they have symptoms most of the day for a week, wheezing, coughing, poor control. If they wake up early in the morning or at night time, they get these things kicking in, especially if they're associated with the extrinsic exacerbations, then that is a definite example. You do your peak flow, your spirometry, and if they score less than 80%, that can be a telltale sign that the person is compensating. Now, when we're dealing with pharmacological treatment and we have an acute episode, most of the time each individual will have their own sort of plan in place. But the idea is to encourage your short-acting beta agonist as your first line via a nebulizer, or mostly these days an MDI with a spacer. The dose and frequency is based on the plan and also the severity of the attack. Often what will happen is you'll get your short-acting muscarinic antagonist mixed into the administration with the short-acting. The person can be on a preventer based on this and the probability of severe attack, so they can be put on oral or inhalant corticosteroid, and they also can need the use of oxygen depending on how bad your actual symptoms are. So the therapeutic guideline for oxygen administration is if an adult is below 93 or a child is below 95, they are to be given oxygen therapy. And oxygen therapy should be low rate and appropriate mask, meaning if you're going to give nasos, give up to 4 litres. If you're going to use a Hudson, don't use any less than 6 litres, things like that. Okay, so you don't want to go straight for the non-rebreather 15 litres if you don't have to. Now, when we're looking at COPD, because this is a progressive and usually associated with massive comorbidities, and the person has been given the diagnosis because their pathological state is not going to get better. The treatment aims is not in curing them, but it's improving their quality of life and minimizing the symptoms that they have. That is the goal of your management. The management approach needs to include pharmacological approach, obviously, but also non-pharmacological. So they have to be encouraged to stop smoking and do their exercise rehab program, okay, associated with increasing the longevity of the lung tissue they have and improving overall function. In regards to pharmacological treatment, they will also be on a short-acting beta agonist. That's for your relievers. So when it gets a little bit too hard, they'll take those relievers. Most of the time, they'll be using the long-acting side of the house for that overall control. They often get put on a combination of those with inhaled corticosteroid, and often these drugs are given as a regime. So the preventative control is put in place with the ability to ramp up with the short-acting ones if required. But each particular case is different. As I mentioned, they often have a lot of comorbidities and things to take into account before prescribing any particular medication. Okay, that's the end of respiratory pharmacology, focusing on asthma and COPD. I hope you got something out of this, and until next time, take care.